What an amazing turnout. Thank you very much indeed. I know Anne-Marie's the draw card, which is great, but I do hope that you enjoy the lunch as well. So just about this session, obviously it's about presenting evidence-based practice, how we might be able to change, increasing our knowledge base, and hopefully you'll be able to take it back and use it in your own areas. If you haven't signed in, please make sure that you do sign in. We do need that for national standards. I'm going to pass out evaluation forms. Again, I need you to fill those in so that we can give feedback to Anne-Marie as to how brilliant her talk was. The pressure's on. So, Dr. Anne-Marie Hill, she's a research fellow based in the School of Physiotherapy and Institute of Health and Rehabilitation Research. She completed her doctoral studies in the area of falls prevention for older hospital patients. She was part of an international project team that conducted a large randomised controlled trial investigating the optimum method of providing falls prevention patient education for older people in the hospital, and then evaluating the falls and the barriers to engagement in exercise after hospital discharge. Welcome, and I'll hand over to you. Thank you.
Thank you, everyone. I'll just preface my talk by saying I hope I don't look too uneasy. I'm trying to not glance over at the video too much, so if I appear to look a bit vague at times, just ignore that. I'm aware that everyone has come during their lunch break, and thank you very much for coming to listen to what I've got to say in what's a very precious time in terms of your break. And also, please don't feel at all reticent or embarrassed if you need to leave at any stage to get back to work or out to do something. Just head off as you need to do that. So I'm not going to be fussed at all if you need to go early. Sue is going to give a handout of my presentation afterwards, so she'll send around probably an email, I would think, with PDF. But if anyone has a particular area or stage in the hospital where they'd like more information about any one thing I talk about, just send me an email afterwards and I'll make sure to send you some information if that's what you'd like. I'm going to just talk about education in general. And if you're going to provide patients with education, you really need some of the basic building blocks of education. So I'm going to talk about those and how they might apply to falls prevention. And then I'm going to illustrate some of what I say by talking about our own 2 research trials that I've been part of, because they directly investigate falls prevention in hospital patients. But remember that there's one thing that I'm not discussing, and that's the multidisciplinary team approach, which of course in your setting is really vital. So I'm speaking from the viewpoint of what would be useful to educate your patients and how you might do that. But you'll need to take that back to your own area and obviously with your own skills and knowledge and your team work out how can we do this consistently so that we're all delivering the same message. Who delivers the message, how does that happen in our ward, so that kind of multidisciplinary team approach is almost another step in the process. That once you feel you're delivering the behaviour change strategies you want, how can you make sure that's a consistent message? So I'll leave you to think about that with your own sites and wards. So just to give you a little bit of background about the current evidence for falls prevention, you will have had some information from Keith earlier this year, I think, and you'll also probably, if you're interested in falls prevention, know that the latest Cochrane review has just come out, and it shows with the meta-analysis that we can be reasonably confident that multifactorial interventions in hospitals reduce rates of falls. So that's good. A little bit inconclusive as to whether they reduce risk of falling. Now, if you look at the trials there, you can see that the evidence is based on 4 trials and some 6,000 participants. So reasonable evidence, good randomised 4 or 5, now 5 to 6 randomised controlled trials done. But before we get feeling really comfortable, remember that if you look at falls prevention in the community and you look at the latest Cochrane review, It analyses over 99 trials and some 65,000 patients. So you can see that although it's good we've got some evidence, we still need to really be on our toes and say, okay, that's all very well, but we really need to drill down into this and find out what's working. And obviously, if it was working really, really well, across Australia, falls rates in hospitals would be coming down, and we're not seeing that yet. So we've probably got a way to go. What about the evidence for falls prevention education in hospitals? That's a lot more sparse. And we've done, Terry Haynes as the project leader and myself as one of the project team, very junior member, we've done the largest randomised controlled trial in the world just looking at patient education alone for falls prevention. And in our trial, we found overall our falls rates didn't reduce, but when we looked at the cognitively intact patients in our trial, then there was a significant reduction in falls. Our trial contained 1,200 patients, and our subgroup analysis of the cognitively intact people was about 850 people. So it wasn't a small group, it was a very large subgroup that we looked at. And just to clarify a bit more, but I'll talk about this later, when we talk about cognitively intact patients, we're meaning people with a short portable mental state questionnaire of about 8 on 10, or a mini mental about 23 on 30. So we're not saying people have no impairment, but what we, I think, clearly showed in our trial is if you look at people with significant cognitive impairment, they're not taking in the strategies that you would like them to take. They're not able to necessarily receive what you'd like them to receive. There's been another trial now, after ours, which provided education for people. It provided people with a 30-minute education session in addition to some targeted interventions. And this did reduce the risk of falling in the group they used. The only thing is there's quite a small, was quite a small number of falls they analysed. So I think they had about 18 to 20 falls, whereas in our trial we were looking at, you know, some 300 falls. So it's a sort of a difference in the size. When you look at the multifactorial trials, most of them use combinations of interventions. So they will do patient education, staff education, using a risk screening tool, doing some exercise, providing low beds, looking at people's medication charts. They'll do all those sorts of activities. And the most recent meta-analyses can't tell you which thing works more or which works less. So, you know, if you do these 4 interventions on your ward, should another ward do the same 4 or completely different 4? There's no knowledge yet of which combination of interventions would work the best. So, as I said, it's still got a way to go. And one of the issues with all these trials is they often use the word, we gave patients education, but there's no description of what they did, or it might have involved something as small as just giving patients a leaflet. So that the variety of education and the type of education isn't really discussed. The most detailed education report is in Terry Haynes' earlier trial from 2004. They did also a multifactorial intervention, put up risk screen charts, gave staff education, provided patients with exercise, and they provided patients with education where they had the occupational therapist gather patients into groups and discuss falls risk with them and discuss strategies in hospital for reducing their falls risk. And when they looked at their multifactorial intervention and analysed it across their whole trial and looked at which components seemed to be working better, they found that the education was actually one of the most powerful ways that the trial had worked. So it was one of the most powerful interventions of their multifactorial suite. And that's what led Terry to think, well, let's actually do a trial where we just do education in addition to all the care people are getting and see whether that education is working. And that's what I'm going to talk to you about a bit later on. But what are some of the concepts in education that you need to know if you're going to do health education for your patients? This is, I think, a really interesting concept if you come from the world of education as well as the world of health, like I do. Because if you're a health professional, you'd be astonished and probably quite offended if I said to you, well, just take that one medication and give all your patients the same dose, the same amount at the same time of day. Or if I said to you, just take that one exercise program and give that to all the patients on that ward, same dose, same time of day, everything, you'd be like, that can't be right. You know, you'd be thinking to yourself, one type of exercise program won't work for all my patients, because it's a very individual thing. Education is exactly the same. Every person learns differently. So if you have a stock way of explaining falls prevention to a patient, then it will almost certainly be suitable for about a quarter of the patients you see, but it'll be completely unsuitable for the other 3/4. Because if you look at most learning styles, they roughly divide into about 4 types of learning styles, allowing for different methodologies and research bases. So the type of information you might give one patient, the way you present it, won't work at all for another patient. And you know that yourself if you reflect even yourself, where you think to yourself, well, I like to read my presentations or PowerPoints, whereas another person might think, well, I like to listen to them. You can think to yourself, when I get a textbook or when I'm given a report in the hospital, am I a person who opens it up, carefully looks through the index, reads the executive summary, goes through? Or am I a person who just gets it, flicks through it, tries to get an overall view of it? Or am I a person who actually just looks at the executive summary only? You all learn differently, you all do things differently. So that's one of the first concepts in education that it's good to think about. And some of you might also be thinking, well, and I'm sure in fact most of you have well worked this out, but I think particularly for newer graduates and our students in health, we can think to ourselves, well, with health treatment, why is education that important? You know, do we really need education? For falls prevention, unfortunately or fortunately, depending on how well we're doing it, it's really crucial, because if you look at the best evidence for falls prevention and you want your patients to have a safe recovery, any person who works in an aged care ward will tell you that you've got all those things you'd like the patient to do. You've got the call bell, you would like the patient to use their frame. In fact, you wanted them to do all the things that will keep them really safe. You want them to report if they feel unwell. You want them to take the amount of fluids you'd like them to have. But unfortunately, there's nothing you can do to make them do that. You need them to do the things you'd like them to do. As a physio, I'm completely hamstrung if the patient can't engage in exercise, unless I intend to do a completely passive modality. You know, I need the patient to do the exercise. I can't do the exercise for them. And that's the key reason education is so important in falls prevention. Unless your patient rings the bell, unless they use the frame you've given them, unless they're willing to tell you that they feel embarrassed to ask you about going to the toilet, they're not going to do those things. They're going to try to do them themselves and they're going to fall over. So that's why the concept of health education is so important. What's some of the background to this? We know that there's quite a lot of evidence in this part of falls prevention, when you look at falls prevention. We know that a lot of older people are still, the most recent evidence from some of these large studies says that a lot of older people don't tell health professionals about their falls. It's not good for various reasons. People will think I'm old and doddery. I fell but I didn't hurt myself, so no need to say anything. We had that in our trial very much in the hospital. You could say to the patients, did you fall over? And they went, yes. And you go, oh, have you told the nurse? Oh, no, I'm okay. So one of the things we know that we should do, and we don't need to wait for another randomised controlled trial, is we as health professionals need to routinely ask our patients about falls. Have you fallen at all? Had any falls? Any trips or slips? Any near losses of balance? We need to actually initiate the asking because they may not tell us. We also know that older people don't see the relevance of a lot of what we'd like them to do in falls prevention. So a very recent large national survey in the UK, which I think was a great way to illustrate some of the views of older people. It presented older people with lots of alternatives and it said, these are the things to do with falls prevention. It didn't actually ask them to go, it just said, would you consider going? And it said, would you consider doing some exercises at home? Would you consider going to a group? Would you consider someone coming out to your home and looking at hazards? Would you consider getting your eyes checked for falls? So I gave people a whole lot of alternatives and said, which ones might you consider? And the idea of this research was to try to draw up a suite of programs so we could encourage more older people to be doing the things they would hopefully benefit from, but provide them with lots of choice. So we could, give them lots of choice. Well, about 60% of older people didn't think they wanted to do any of them. So weren't interested in any of what was on offer, regardless of their falls risk. So I think that shows us that we've still got quite a way to go with older people. When you try to focus down on falls in hospitals and older people's attitudes, we already know from large studies that up to 90% of falls are unwitnessed in hospitals. So that tells us how important education is. Because the older person has done something where they have misjudged the task that they have chosen to do. They have misjudged their falls risk or misjudged their ability to do something, and they've fallen over. So they haven't asked a staff member to help them. So it's a key, isn't it, warning bell for us that falls are happening unwitnessed, because it suggests the patient is not attuned to what we'd like them to be. And another study which has been replicated in smaller qualitative studies, but this is a very large study, looked at falls and found that of all the 200 falls events that they had in their hospital, large academic hospital in the US, in only about 3% of those falls had the patient rung the bell before they got up and fell. So it wasn't that the patient had rung the bell, got impatient and thought, oh, I can do it myself, and then fallen. The patients weren't aware that they had mobility of a level where they should ring the bell. So ringing the bell is not a thing that patients understand, I think, the way you and I understand. So that tells us that education is important. And then when we ask older people about the education itself, so we think, well, okay, let's say it's really important. What we find from lots of large studies now, qualitative studies, that older people don't think falls prevention is relevant for them. It's relevant for those other patients because they are very wobbly, but not so much for me. I'm pretty good. Older people don't have good knowledge about falls prevention strategies, so they don't always have the knowledge at their fingertips that we'd like them to have. And some of the education that's been done, when they've then asked older people to evaluate it, they've reported that they find it very confusing and rather patronising. The study by Carroll that I've referenced there is very interesting because they interviewed some older people after they went home from hospital who had fallen. And the older people had a variety and range of points to make. Some of it were indignation. Well, I fell over, but nobody told me anything about falling over. I don't know what happened. Some people said, well, I'm feeling a bit aggrieved because I fell over, but I did what one staff member said, but it wasn't what the other person said. Some people said, well, things weren't set out in a way I could use them, and I think, that's why I fell over, and it's a bit unfair, you've got this difficult environment. So they had all sorts of responses to what the staff were perceiving was, we've got our people on the ward, we're giving them the right information. But the older people weren't receiving it in a way that they could understand and take it forward. And of course, just finally, when we're talking about the overall, why do we want to do education for falls? We know that falls is a serious issue. It's made it onto the National Safety and Quality Health Standards because it's such a serious problem. And we know that one of the criteria that has been set for meeting that standard, and there's a number of criteria, and it's obviously based on the best evidence and trying to say what can we get each hospital to do nationally to reduce our falls rates. And one of the criteria is communicating with patients and carers. Now, I just want to draw your attention to the second part of that statement. Remember that we want to inform patients about their risk of falls, but we need to engage them in the plan. So I can tell you about falls, but that will not be of much value in this talk if I can't get you to think when you go back, well, let me think, Anne-Marie did mention that about education. I might try that with the patient. It will be of no value if it's not information you can use afterwards. So that's what we need our patients to do. We need them to engage with us in the plan. Health education is different to other education. If you think about it, often we're thinking if we go to uni, we'll get a whole lot of information. If we're in primary or high school, get a whole lot of information. There's not always a suggestion that we do anything with it, particularly if we start with a basic science degree. No one suggests that at the end of the day, measuring the amount of weight of a protozoa, you go home and that'll be handy for you when you get home. You'll be able to use that when you're out shopping. You know, no one really suggests that being sure you are able to use your SBS statistics and you're able to calculate to the third decimal place a logistic regression model, that's not really going to help you at the footy. You know, it's not really that useful. But when you give people health education, when you tell people on the ward your blood sugar is 11 point something, you're not just telling them that, you're going to go on to say, therefore, that's not so good for your vital organs and other systems, and therefore I need you to engage in this behaviour. So health education is not really education, it's more about behaviour change. So that's a really good fundamental mindset to put yourself in. So whenever you speak to a patient, remember, I'm not kind of giving them information or a lecture or something like that. I'm actually trying to tell them something that will help them to engage in a certain behaviour that I'd like them to engage in. Not always instantly, but I'm trying to give them the correct level, amount of information that will help them to be able to be the best they can be in the setting. You know, so that would be, for me as a physio, a good example would be giving people some information about why their exercises are important, but also giving them a printed list so they can see them after a go, making sure to go through the exercises with them and say, do you feel confident you can practice these? And getting some agreements on them. Yes, I think I could do them once a day. All right, that'll be good. And finally going off to the nurse and saying, oh, by the way, Mr. X, I asked him to do his exercises at 10 o'clock. Would you mind reminding him? So, you know, it involves a whole lot of steps that will hopefully help Mr. X to engage in his exercises. So what I'd like to do is go over some of the concepts in health education, and in terms of these concepts, there's a lot of evidence for these. So what we can do is take some things that are very well researched and we can superimpose them on falls prevention education and say, okay, we know this works already. Whatever we're telling our patients about falls prevention, these are certainly some of the steps that a high quality program in our hospital will need to contain. Or these are some of the steps that if I as a health professional want to talk to any one of my patients about falls prevention or engagement in exercise or when they go home engaging in certain sorts of behaviours that I'd like them to do, these are the steps I'm going to need to follow if I want them to be able to do that. So I'm just going to go over these very briefly, and I've noted on the bottom that motivational interviewing is also a great skill to have when you're working with patients, and there's a really good motivational interviewing webinar on the ICWA website, so you can easily go to that as well. But I'm just going to talk about 4 key concepts in health behaviour change, health education. I think the first thing to do whenever you're talking about education is you have to talk about communication. So it's going to be you and your patient, or you and your patients in a group. So communication when you want to do education is really vital. When you look at communication and falls risk, there's been a couple of good studies on this. And one of the problems is I'm speaking Italian and the patient's speaking Greek. This is one of the key problems with falls prevention. as a health professional, and I can see the range of people we've got in this room are strong in allied health. In allied health, if you talk to even a new graduate, they'll say, well, you know, falls are due to these risk factors. So they're like, yes, that's right, really good information. They list you out the risk factors and say, so if I want to stop someone from falling, I should give them some exercise, try to address home hazards, make sure I ensure they've got the latest equipment, remind them about their podiatry and their foot, remind them about their vision, and that will all reduce their falls risk, and they'll hopefully fall a lot less. You know, we'll be addressing that. Older people consistently, what these studies show, older people think falls are an accident. They're something that they just happen. They just happen. You don't know when they're coming and how you're going to stop them. And so there's something to avoid. There's something that they're accidents, and you try to make sure you don't have an accident. And if you do have an accident, you get around that by avoiding, in often cases, doing the tasks that you were doing. So if you're out shopping and you fall, you ask your daughter if they'll go shopping for you. Or if you're fiercely independent, you just think, I don't care, I'm still going to go shopping, but you feel very stressed and anxious the whole time you're out, thinking, I hope I don't fall over, I won't go into that shop, I'll just go to this other shop, because that'll be safer. So you have that kind of attitude, and that's why when you ask older people in hospitals or in the community, if you ask your patients, if you go back and as a little test, say to one of your patients, so how are you feeling about yourself being on the ward? Are you seeing yourself at risk of falls at all? For a start, a lot of them will probably just go, oh no, I'm not at risk of falls. I'm very safe in here in hospital. But secondly, once you go by that question, say, so have you thought of anything you should be doing to prevent yourself from falling? You'll find people come out with the answer of, well, I've got to be careful. You know, falls are this accident, I've got to be careful. So very few patients will say something to you like, well, what I've got to remember is that I've got this weak leg and I need to use my frame, and also if I keep doing my balance exercises, my balance will improve and I'll fall less. So it's important to try to first get on side with the patients and pick up this kind of dichotomy of views that we have, so you don't talk on one level and they secretly are thinking, well, you know, put my glasses on, I don't see the relevance to that. You know, so that's one of the first things that's very important in falls prevention. Also, think about your learning styles. You know, all our patients are different. If you're an activist learner, what sort of baby names, what names would you give a baby if you were going to have a baby? Or is anybody here going to have a baby? I hope I'm not speaking, you know, letting out your secret. But what names would you give a baby? So people have done research and all these sorts of things. So, you know, if you're an activist, you give the modern, up-to-date name. But if you're a person who's the deep thinker, the historian, the reflector, you like the tried and true names that have gone through the centuries. Or are you the theorist? You know, I've got to be careful not to give my baby that name because that's the name of a pop star. You know, can't do it. You know, so you learn differently, you think differently. What about cars? What sort of car do you drive? Your car says a lot about your learning style. Are you a reflector? You're driving around your old 1960s Morris Minor and people think you're very strange, but you're determined to keep it forever. You love it. As opposed to me, who once the car gets over 40,000 kilometres, I keep saying to my husband, this is an old car. I hate this car. It's old. It's really old. It's got a dent. I can't drive it. You know, so what sort of person are you? Remember, all our patients are different. So giving each person the same information in the same way will not work. You have to think to yourself, what sort of person is this? What's their background? How do they learn? What do they do? And you've got to tailor the way you speak and interact with them. If you do that, you become one of those people that becomes very good at working with your patients because they instinctively feel, oh, that person seems to understand me. What you're understanding sometimes is not so much them, I always think, but I think sometimes I'm just understanding that they're different to me. The fact that I think of myself as maybe, yes, I like that idea of a red racing car, it's kind of appealing, is not going to be appealing to the other 3/4 of the population. So thinking about learning styles first is very helpful. So let's just go on and talk very briefly about these concepts. So I'm going to just go over them very briefly. The first one is health literacy. Health literacy simply means the understanding of health and how you get help for your health, what you need to do. So for example, if I'm asked to take medicine, where would I get that medicine? Can I read the packet? Do I understand how many times I'm meant to take it? A lot of evidence in this area. And we know that about 60% of all Australians lack basic health literacy. That's a very important thing to try to absorb. So just remember, in this room, all of us are in the highest percentile of health literacy. We all have high levels of health literacy at our fingertips. When you meet patients, over half of them have no knowledge or very limited knowledge about health literacy, which is why we get such serious problems when people are asked to take warfarin and they don't understand the whole ramifications of why the warfarin's important. It's why patients keep getting out of bed and falling over, because they don't understand about it, so we need to ring the bell. And there's a lot of very good evidence to say that poor health literacy equals poor health outcomes. And I've just pulled you out this one little example, showing that people with low functional health literacy are much more likely to be admitted to hospital, are much more likely to have health diseases. And people with low functional health literacy, there's been a number of studies in different areas, and when you have low functional health literacy, you have much worse outcomes. So what I've done is, first of all, pull you a slide that I hope illustrates giving people with low functional health literacy a poor message. So a message where they're not really understanding it, to hopefully, if I was giving you a message, this is the message and the way I'd give it. Something that's clear and simple, something that you understand. I've hopefully given you some practical tips at the end there, like about tailoring your communication for the patients, and I've presented it clearly. So that's what you're hoping to do with your patients. Now I'm going to talk very briefly about self-efficacy. Another concept in health education is remembering that if your patients don't see any value in something, they won't do it. None of us would come to our job if we disliked it and we weren't paid. So there's no way you would arrive here at the hospital this morning if you were receiving no pay and you also disliked the job. It's not what human nature is about. So we need to understand that our patients have to have some ability to understand what we'd like them to do, and they have to see some positive benefit in it, or they're just simply, they're not going to be necessarily angry and averse to doing it, but they're just not going to see any reason or remember to do it. Just going to go right out of their mind because no particular reason to do it. So we need to be sure that they understand that they're the ones that are going to do it. It would be nice if we could make them do it. We're possibly not going to be able to use that method. So we really need our patients to engage in the behaviours we'd like them to. Again, come back and try to remember that you're on the opposite side of the fence. You have the really high health literacy. Remember that you're thinking the easiest thing in the world is just to ring a bell. Many patients come into hospital and spend, and I know this from discussion with the 350 patients in my trial, many patients are morbidly sensible about, should I ring the bell or will that be a bother? I've rung it 2 times already. Better not ring it till after lunch. I'm sure that would be a bother. So our patients are thinking on those kind of levels, so we need to be sure that we encourage them and give them that feedback and go, wow, yeah, right thing, ring the bell whenever you need, no problem. And we go, oh, okay, I'm doing the right thing, I'm getting the self-efficacy. So very important for our patients. Finally, what about tailoring? Targeting and tailoring are important concepts in health education, and I'm going over in one slide what there's a whole research world about, but just to give you that kind of quick overview for yourself. Targeting is when you go onto the ward and you make sure all your patients get information about home health or exercises or falls prevention. So you say, okay, remember, you've got to ring the bell, check the chair is low, don't get in that chair if you see it's been raised up, put your slippers on. That's the targeting. Tailoring is where you pick one patient, or you take any one of your patients and you specifically adjust the information for them. So you say, okay, patient X has poor vision. So when you go to see them, you say, Now I need you to ring the bell. Can you feel the bell? Where would it best be with your poor vision that you could see it? And you talk about the information in a way that's directly relevant for them. Nearly all evidence and many large trials show that that tailored approach works better at getting people to adhere to things. So if you think about it, the big evidence in areas like smoking, those sorts of things. You know, if you want to quit smoking, you don't just give people a brochure, you try to tailor it for their lifestyle. So very important, and particularly important for falls prevention where everyone has individual risk factors. So that kind of single message of make sure you wait for help is going to be somewhat helpful and better than doing nothing, but isn't going to be as helpful as reminding each patient what you would like them to do and what you see as valuable for them. And finally, just to really, hopefully not totally overload you, but trying to give you all these nice concepts just so you can think about them. Health education works on a number of really well-defined theories, and these are, again, really well evidence-based. And they came about, health education started in about the 50s when people began to develop things like vaccinations. And for example, one of the earliest was TB. That's a big starting point for health education, where they developed this vaccine and thought, great, you know, we will stop TB in its tracks, and then discovered, gee, no one is taking up the vaccine. And they had to work out, and they thought it wasn't a matter of it was free, it was available to everyone. And they began to see that, gee, people with low education don't take it up, or people who have different beliefs don't take it up, or people who don't think they'll get TB, who don't have an understanding of immunity, don't take it up. So this was what led to health education theory. So if you have a look at this chart, you can see that at the end you want your patients, and I'll just do this so I've remembered, I'm going to tell you now about the slide. You want your patients to participate in falls prevention activities on the ward because it's going to lead to fewer falls. So you want them to do that. However, if you're going to do that, you need them to feel that they're going to do it, that they're going to intend to do those strategies. If you want them to do that, you need to be sure that they understand that they will benefit from this and that the benefit will outweigh any costs. You know, if I ring the bell, that will mean I'm a bit less independent. So that's a little bit of a cost. And the way you do that is by, first of all, developing in them that awareness of a risk. You know, by the way, we have falls in hospitals. It's one of the issues of hospitals. They're for various reasons. Talking about the patient. You need them to develop knowledge of what sort of strategies they use, and then you need them to get that integration of their perceptions and beliefs where they're going to take up their strategies. So that's a kind of very simple idea of how health education works. But an even simpler way, just to keep on your mind, is you want your patients to develop the capability. So you want them to clearly understand what you need them to do, but they need to have the motivation. You've got to have explained it well and given them the guides so they feel motivated to do it. And finally, you need to clearly tell them when the opportunity arises. So you need to say, this is when you ring the bell. This is when you're at risk of falls. Not out there in the corridor, here by your bedside. And once they engage in the behaviour, you've got to give them the positive feedback. That was great. It's good to see you using your frame. I know it's going to help you get stronger. You're going to be able to go home safely. So it's a nice, simple way to talk about it. Remember, not the kind of, don't give people those simple messages. Give them those messages that are tailored and subtle, and the messages that are nice and simple in a way that's simple for them, but isn't just you telling them something to do. So I'm just going to go on and talk a little bit about our education now, just very briefly. I conducted a trial prior to our large trial where I tested looking at would patients understand a DVD for falls prevention better than a workbook, and basically found that the DVD was more well received by patients. So people could remember what was on a DVD better than reading the information. Probably related to those concepts we've been talking about, functional health literacy, other concepts like that. And we also found that when we provided people with the education either with the workbook or DVD, those people were significantly better than control group patients. So of the 100 people who didn't receive the education, they knew significantly less about falls than the people I gave the education to. So the people I gave the education, if you said to them, where do falls most happen? They could go, in here, in my bedroom near the bed. 90% of them knew that was the place you had to really watch out for. If you said to them, what's one of the key things to do? 90% of them could say, well, the most falls happen in the morning when the staff are busy, so you've got to be sure then that you wait for help if you need help. So they were significantly better than people that didn't get the education. So what we did, Terry Haynes got an NHMRC grant, and we conducted a large trial, and we gave a group of people, it was a randomised controlled trial, and we gave people the education. And we had 3 groups. We had obviously our control group. We had a group where we gave people the video to watch and the workbook to read as well, but we didn't follow up personally. So that might be what you would consider the targeted intervention. And then we had a full group, what we called the full education intervention, where we gave people the video, showed them the workbook, and then myself or another physio followed up with them and said, okay, let's work out, how does this apply to you? What would you be doing about that? And what we found was, when we looked at our overall rate of injury, we didn't notice a significant difference. But when we looked at the cognitively intact patients, some 900 patients, we saw that almost instantly from people first being admitted to hospital, our complete program in the black line, there was a significant reduction in falls. So people who were cognitively intact fell less than 50% of the time. So it was a really, really exciting result. But what we found was people who were cognitively impaired had a higher rate of injuries when they received the education. So the education, we had the same amount of fallers, but it didn't help people who were cognitively intact, and they had more injuries. So we don't know if that could relate to mobility. I suppose people might have mobilised more, but certainly it didn't help those people. So we've taken our program and we're now trialling it in hospitals in WA as part of a SHRAC project. And the GEM unit here is going to start with this program soon. And we're relying on our falls prevention community of practice actually. And what we're going to do is provide our new program to patients on the GEM unit who are cognitively intact. And hopefully that will drive down the rates of falls in those patients, which we are very confident it will. The interesting analysis for us will also be, is it economically viable? It certainly was in our trial. The cost of providing our therapists to deliver the program was far outweighed by the cost of the falls, so we feel it could be very economical. And what we'll be interested to look at is, will driving down rates of falls with cognitively intact patients, how will that impact on rates of falls overall? Because obviously cognitively impaired patients fall at an increased rate, so will it drive the whole rate down? But either way, I always point out to people that I'm talking with about it, we're happy to have an intervention that stops cognitively intact patients falling over. And it really ticks the box of saying, well, at least that's one group that we can be sure we can get to fall over less, we can give them the right sort of education. Maybe that will free up our staff a little bit more for the cognitively impaired people, because we've got a group of patients on the ward that are more engaged and know what they should be doing for falls prevention. So there's a number of interesting ways, and we'll be hopefully looking at all that as the program goes. Just to point out to you the trial, we're looking at, we started with everybody in the control group, and we're slowly rolling out the trial there across the sites. And Charles Gardner is site 5, so we'll be starting at Charles Gardner and Bentley. So we roll out slowly, and we've had very good feedback and good results so far at the 2 sites we've been going the longest, which is Armidale and Swans. So fantastic results there so far for the patients who've had the education. And I'm just going to finish up by giving you an example of another education example. And this is my trial that I've just had published. So only just published 2 weeks ago. So handy I can talk to you about it. And what I became very interested in was the falls rates after discharge, which are very high. And I won't go into those rates today. But we know that when people go home from hospital, they're functionally declined. We know that people get sent home very early, of course, from hospitals these days. And we know that there's increased falls rates in that post-discharge period. So what I did was design a whole new DVD, a whole new workbook and a whole new education program, and conducted a trial just recently and gave it to patients who were just ready to leave the hospital. So when they were all ready for discharge, rehabilitation patients, and the discharge date was coming up, they participated in my education. And knowing what I knew from our earlier trial, I enrolled people with mini-mental over 23 on 30, so could have some cognitive impairment but had to be able to receive the intervention and engage in the behaviours. And I measured people's engagement in the falls prevention strategies for 1 month, and also the number of falls and falls injuries. So similar type to the intervention that we found successful in hospital. I gave them a telephone call after discharge to talk about it with them. And just to give you a very, just a quick snippet of sort of what the education focused on, what I focused on was a 3-step message. So how could I tailor the education for them but put it in a way people would understand? So I gave them the message of plan for some help when you first go home from hospital. You're probably not yourself yet. Plan for some help. I then gave them the message, return to your normal self gradually. So we talked about, that concept, I'm not better. Okay, I've got 2 choices. I turn into an invalid and do nothing. I start doing things myself normally and just pretend I'm normal, but then I fall over. Or I hopefully do this. I work out what's a strategy where I can gradually get myself back to my best. And thirdly, I talked about make sure you do some regular exercises. So differentiating that from walking. Besides your keeping fit, cardiovascular exercise, as we know that falls prevention, it's important to do some balance work. So saying to them, at your own level, it's very important to do some simple balance work. And that was that was the basis of the intervention. I found that I had good results in that the people in the intervention group were much more likely to engage in the sorts of strategies that I wanted them to, so that was fantastic. And in my trial, which, as I say, has just been published, I had, in the month after discharge, we had 5 falls in the intervention group and 19 in the control group. So it, I think, really, again, shows when you give older people the right sort of education, you make it easy for them to understand why they should do something, how to do it, and what to do. So we're hoping to roll that out a little bit more too. So it was a really good result, and I think again indicates the sort of results you can get with health behaviour change modalities. So just to give you a practical summary, and as mentioned, I've stayed a little bit on the individual patient level, but really these things can work fantastically at a ward level, and that's what we hope the SHRAC trial will do, that it will get all staff on the GEM unit thinking, okay, these patients are getting this education, I'll just make sure I remind them, I'll make sure that I fit in with that. But on an individual level, remember that you want to provide tailored advice. So don't give people a generic message. Each patient needs their own message. Remember that you need to provide knowledge, but you also need to address the beliefs and the barriers and make sure people understand you. You need to give positive views on ageing so that you can encourage self-efficacy. So you need to say to people, you can do it. It doesn't matter that you're 80. That doesn't mean you can't get better. These are the things you can do. So you need to give those positive messages. You need to help people to understand. Just remember, this is where education pulls in evidence from other areas. We already know in the area of falls prevention, and I found this in my own trial with exercise, older people are significantly, so remember that's the research where that means significant in statistics, which is very important. Older people are significantly more likely to do something if it's recommended by you. So if you as a health professional, in a respectful, I'm not telling you to do this, I'm asking, but if you say, I recommend, I'm suggesting that you use the bell because I feel it will be the best thing, it'll keep you safe, if you get a bit of help off me now, you're sure to stay safe in hospital, you'll be able to go home. You make it significantly more likely your patients will do that. It has to be an overt statement from you. Many times what patients pick up is, if you as the physio, I'll take a physio example for a minute, if you as a physio ask patients to do exercise, but you don't overtly say, these exercises are really good for you, I am confident they'll get you better, let's progress this, because the fact that you're 90 is nothing to do with the exercise, we can get you better. If you don't have that discussion, when I have discussions with my patients who are supposedly doing all those things, what they pick up if you don't say that is, well, of course the physio has to see everybody on the ward, of course they're going to give me exercise, but they probably don't think they're useful for me. You know, it's probably just that they have to do it. And the older person themselves is thinking, I've had 3 friends who've all fractured their hip, and look where they are now, they're not better, therefore now I've fractured my hip, I won't get better either. And you can see how those 2 powerful messages can prevent your patients from doing what you'd like them to do. So that's why you need to say to them, these are the things we want you to do on the ward. We strongly believe that they're going to help you get better. Very important to give people that message. Remember that people need the message, and they need simple, clear advice and smart goals. So they need those really definitive. Now I know when I'm speaking to allied health, smart goals are something everyone understands. So they need that, not the message, don't be careful. They need the message, ring your bell. When you're sitting here, if you're, I want you to be sure to, if you could, drink that amount of fluids because you're still a bit dry. You know, they need that really simple, tailored goal. Because what you're wanting them to do is get that message, look, we've got you here, we want to keep you safe till you go home. So that's the kind of health behaviour message that you wanted to deliver to them in the area of falls prevention. Now, I'm just aware that everyone has to go, but very happy to take a couple of questions if people would like.
Is there any questions in the room first before I go to BC?
Sorry if this sounds stupid. What are you defining as an older person? What age bracket are we talking here?
Well, we know that people in hospital over the age of 60, that's where we start saying really they're at risk of falls, increasing risk of falls as people get older. So as soon as people are over the age of 55, 60, you would be wanting to focus on giving them the falls prevention message if they're a hospital patient. But we do know that patients on medical wards and patients on aged care and rehabilitation wards, those falls rates are very, very high. So if you're on a medical ward and if you're on a rehabilitation ward, I'd be trying to make sure all my patients who were cognitively intact were getting this message. Any other questions?
Anybody on VC that, anybody on VC that wants to ask any questions? No? All quiet, so go ahead.
With your the research that indicated that there was an increase in falls with the cognitively impaired, what did you lead to think about that?
Yes, what we found was that there was a definite divide line. We found that it was very effective for people who are cognitively intact. With cognitively impaired people, we actually didn't have a significant difference in the number of fallers, but what we found were falls in our group were more injurious. We put that down to cognitive overload, in that people with cognitive impairment are already confused and they're on a ward and they're not feeling well. So any intervention, we at that stage would have been saying to them things like, remember to ring the bell, but we think that probably was, you know, too much information. And what we found also was that people with cognitive impairment misinterpreted the message. So I had some patients where I would say something to them like, you might say, just sit here and, you know, when staff come, then you'd ring the bell, you know, if you need to go to the bathroom. But the patient might think to themselves, oh, I need to go to the bathroom, so I go to the bathroom and then when I get back I ring the bell. You know, they just may, or that they misinterpret the messages that you think you're giving them. So I think it was a very clear indication of why it's not useful to tell cognitively impaired patients, you know, like, I'm putting the bell in your hand, make sure you ring it. I think you just leave yourself open to them interpreting that in a number of different ways. So we feel it's that, too many messages and they just don't pick up on them.
And so that has led the unit to do something else?
Oh yes, I think
Or
that,
withdraw,
yes,
or-
yes, I think what it led, firstly for me as a researcher, what it says is we need to look at cognitively impaired people in hospitals and work out more how do we stop those people from falling. Like multifactorial strategies that we're using now, not though education for those people. We need to work out what extra or different things should we be doing.
Awesome.
And Mary, this is Raja here from Selby Lodge.
Oh, hello, Raja.
Yeah, can I ask you a question in regards to functional health literacy? How would you determine that? Which level would you say their functional health literacy is good or acceptable and this is not acceptable?
Yes, I think there's a number of well-validated tools, Raja, but most of those are research tools. And I think for your own patients, a couple of simple practical strategies are firstly to just assess their own knowledge of their health condition by asking them things like, have you had falls before? Has anybody told you about falls? Getting an idea of what they know. It will be related also to their own level of education. So generally, if people have had high school to tertiary education, they are more likely to be functional health literate. And also just assessing to see if they've had any other type of scenario that might help them. So for example, have they attended a patient support group, or have they got a pharmacist that's been working with them with their medications? If people haven't talked with their pharmacist about medications, I become very uneasy because most people, older people particularly, don't always have a good grasp on their medications. So that to me would be some of the practical ways I'd assess people's functional health literacy. Does that answer your question, Raja?
Yes, thanks, Anne.
Thanks.
Okay, thank you very much, everybody,